I try to cover as much as possible. I have around 70 slides, but I don't think I could able to run all those slides. So, the normal pattern of breathing, what we breathe about more than 8 billion times during an average lifespan. So that it creates a negative pressure. Our intrapleural pressure drops. The pressure at the mouth is 0 and your intrapleural pressure or intrathoracic pressure becomes negative. That's how we suck in air. But what we do in mechanical ventilation is exactly opposite. We push air into the lungs against some resistance. Imagine that our respiratory system, like our airways and lungs, to be a tube at the end of which there are balloons. So the pressure which is required to overcome the resistance of the tube and then to expand the balloons, which is at the end of this tube, is what the mechanical ventilator does. So it pushes the air through the airways. To push that air, it has to overcome some resistance, and once the resistance is overcome, the alveoli, which is at the end of the airways, they open up. So overall, the pressure which is required is a combination of the work which needs to overcome the resistance as well as to overcome the elastance. Elastance is the alveoli tend to collapse. So we calculate these pressures as per the, So we'll be discussing these aspects in the next 15 minutes. Inside the lungs, and then the air gets into the lungs, and during exhalation it's a passive process. The chest wall and the rib cage collapses and the expiration is passive. But what we do in positive pressure ventilation is we push in air against a force. So that's how the lung expands. So the equation of motion is, so our muscles generate some pressure or force, as well as the ventilator delivers some force. So these two together overcomes the resistive forces which requires to move the air through the airway and as well as to expand the alveoli. So the equation of motion is, so the combined transrespiratory pressure which is required is elastance, or which is otherwise reciprocal of compliance. Elastance into volume plus your resistance into flow, and there is a constant which is the peak and expiratory pressure. So this is what is the equation of motion which describes pressure, flow and volume. Next. In positive pressure ventilation, again, so there are some controls, which you have to set before you initiate this process of mechanical breathing. So you have a ventilator control system, which is a complex system with a lot of microprocessors, valves inside the ventilator, and you have the ventilator panel. Normally what we make changes through. So the control panel basically is the interface which will have a screen along with the knobs where you can set the different parameters like your peak inspiratory pressure, your PEEP, your inspiratory time, your respiratory rate, your FiO2 and trigger. So these parameters will ultimately regulate the 4 variables, which is the flow, volume, pressure and your time. So the other important components being the circuit and the humidifier. So because we will bypass the upper airway, the gases which goes into the lungs needs to be humidified. Otherwise there will be like drying of the airways and there will be blockage of the tubes. So there are some variables like constant variables basing on which you decide what is the mode of ventilation. If it is so the constant variables are these, like pressure, volume, flow and time. When you have pressure as the constant variable, you call it as pressure controlled ventilation. So pressure you will set, the other variables like flow and volume will vary. Similarly with volume control, The volume will be the set parameter, your pressure and flow will vary. So how a breath is defined? When you have a pressure waveform which doesn't changes, means it is a pressure controlled ventilation. So your flow and volume will vary. And when you have a volume waveform where your volume or flow doesn't changes but the pressure changes, then it defines your volume control mode. So basically out of the 4 parameters, one will be the control or set parameter, either the pressure, the volume, the flow. So the other changes as per the dynamics of the airways and lungs. So pressure control versus volume control, you can see the pressure waveform is more or less a square wave waveform, whereas the volume, it increases at the beginning of inspiration, then slowly it decays and there is an exponential decline. So in volume control, the volume remains constant and the pressure changes. So the phases of breathing while the child is on a ventilator is, it switches from exhalation to inspiration, then the inspiration continues, then the inspiration cycles to expiration, then the exhalation starts. So basically we will see this in the ventilatory graphics. So basically the main aim while you set the ventilator is set some parameters, like if you are setting on a pressure controlled ventilation, you set pressure, how much pressure needs to be set. So that is again determined basing on the disease process. So whether it is an obstructive, the disease is having an obstructive component like your bronchiolitis, bronchial asthma, or a disease of decreased compliance like your ARDS or pneumonia. So basing on that, you can select your mode and you can set the parameters. There is nothing specific that you set the pressure by this much, rate by this much, FiO2. So it all depends on certain clinical criteria where you have to look at. So apart from the control or constant variables, you have the phase variables. What are the phase variables? Phase variables are the variables which initiates, sustains and then ends a cycle. So what is that variable that initiates? It's the trigger. So there is a setting in the ventilator where you need to set your trigger. In a child who has not been heavily sedated, where you are allowing the child to breathe spontaneously as in a SIMB, you need to set the trigger. Trigger can be like again time trigger, or it can be, we'll discuss that. Trigger, limit is what the amount of pressure or volume that will be delivered during the inspiratory time. And once the limit is reached, the ventilator will cycle into the exhalation mode. So again, this trigger can be time triggered, as I told you, like you will set a time during which if the patient is triggering a breath, then the ventilator will support. If the patient doesn't trigger, then there will be a backup ventilation where your breath will be given by the ventilator. So sensitivity, again sensitivity is important for triggering. Either it can be flow sensitivity or pressure sensitivity. In flow sensitivity, there is a continuous bias flow, means there will be a continuous flow in the ventilator tubings. The moment the patient tries to breathe, the patient will suck little bit of air. Then there will be a drop in flow. This will be sensed by the ventilator and the ventilator will trigger a breath. And in pressure sensitivity, you need to set the pressure. Pressure sensitivity, you need to set the pressure. Normally it is -1, -2, -3. That means if you have set towards the more negative side, the patient had to make, as I told you in the beginning, the pleural pressure has to drop for the patient to take a spontaneous breath. If you set the pressure trigger too negative, the patient has to make an effort to make it that much negative so that a breath is initiated. So always these are important when you deal with patient who is fighting with the ventilator, when there is lot of asynchrony. So limit variables, again it can be pressure limited or volume limited. Again the cycle variables are like this time cycle, volume cycle or pressure cycle. So usually the cycling will happen when 30 to 40% of the peak flow has been achieved. So again the goals of ventilation and the indications, all of us are aware of this. So again, the important thing is you should know your ventilator. Rather than having so many machines with you, you have to be confident and you have to be comfortable with the one you handle. The ventilatory circuit, again the humidification. Then the one more important aspect while you set a ventilator is your alarm settings. If you don't set your alarm settings appropriately, then it keeps on giving you the alarms. So normally when you set PIP, PIP is the pressure which will give you an idea about the chest rise. When you set PIP, it means that you have to see the chest rise. So again, when you set an alarm, it has to be 5 to 10 centimeter of water above your PIP. Again, when you set your PEEP, PEEP is what determines the what prevents the alveoli from collapsing, the pressure which remains in the alveoli at the end of expiration. So when you set again the lower pressure limit, it has to be again 5 to 10 centimeter below the lower limit. So again, the requisite before putting on a ventilator is the indication, the nature of illness, the local, whether it's a localized disease or a diffuse disease. Then again, other aspects of when you put the child on ventilator, you have to take care of the sedation, analgesia, and the other hemodynamic parameters. So as I told you, the basic settings will be your PIP, which is set as per the chest rise. When you set your PIP, you have to observe for the chest rise. So normally in pressure controlled ventilators, you set your PIP. In volume controlled ventilation, you set your tidal volume. So this will be the control parameter in pressure controlled ventilation is your PIP, whereas in volume controlled ventilation, it will be your tidal volume. So PEEP, again, irrespective of the disease, you set your PEEP, except in your, cases of bronchial asthma, bronchiolitis, where there will be lot of auto PEEP. Auto PEEP means there is already so much of air trapping, which will be difficult for the patient to trigger a spontaneous breath. In those cases, you set your PEEP on the lower side. Again, zero PEEP in asthma is not beneficial. You have to set some PEEP so that it helps in splinting the airway. Splinting the airway means already there is negative pressure in the lungs. So much of positive pressure. So in order to overcome the positive pressure and prevent the airways from collapsing, you have to set minimal PEEP, even in cases of obstructive airway disease. Set respiratory rate as per the physiological age of the child and FiO2 as per your requirement. Flow, most of the ventilators will have a bias flow. So we discussed this PIP, PEEP. Again, you have this PV loop. So in this PV loop, what is known as hysteresis, you can see the lower red dot, which is known as lower inflection point. What is lower inflection point? The point at which the alveoli opens up. So once the alveoli open, you can see the horizontal line is the pressure, the vertical line is volume. Once the alveoli opens up, there is a sharp increase in the volume. That is where the importance of keeping your PEEP. So normally the PEEP is kept just above the lower inflection point. Once the alveoli are open, it's just like at the start of blowing a balloon, it will be difficult. But once you blow the balloon to some volume, it becomes, you can easily blow it. So the same thing. So keep the lower red dot is your lower inflection point. Your PEEP should be just above the LIT or lower inflection point. The upper red dot is your upper inflection point. Beyond that, if you increase the pressure, you are going to cause over distension and your ventilator induced lung injury or volume trauma will be more. So your PIP should be little bit lower than the upper dot, which is the upper inflection point. This is the inspiratory limb. And when you come on the other side, which is expiration, you see a point comes where the lung volume suddenly drops. That is known as the closing capacity, or which is known as the deflection point. So again, setting the I ratio. I ratio is usually by default it is set 1:2. But in cases where there is air trapping, like in asthma, there is lot of, because of bronchospasm, the expiration is prolonged. In those cases, you have to keep your inspiratory or expiratory time longer. In cases of obstructive diseases. Yeah. So when you have a component of obstruction like bronchospasm where you need to prolong your expiration, so your expiratory time should be more.
Like and subscribe Eagle Media Works.